Hello, everybody, and welcome to PathoLogic. Today we're going to be discussing coagulation and coagulation disturbances. Hemostasis, or coagulation, is critical for the body to prevent blood loss. It occurs from three distinct processes: primary hemostasis, which forms the platelet plug that stops initial bleeding; secondary hemostasis, which forms fibrin and the blood clot; and fibrinolysis, which breaks down the blood clot to restore normal blood flow. Note that these processes can occur simultaneously, although we typically think of them in sequential order. Primary hemostasis is the initial vascular and platelet response to an injury. It stops blood flow until a clot can form. Key components in this step are the platelets, endothelial cells, platelet adhesion proteins, and platelet activators like thromboxane and ADP. After a vascular injury, von Willebrand factor on the underlying collagen is exposed. This factor binds to GP1B on platelets, and the exposed collagen can also bind to GP1A and 2A on the platelets. Binding to von Willebrand factor induces a shape change in the platelets that we call activation. Activated platelets are going to release granules that contain ADP and thromboxane into the local circulation. ADP is going to activate other platelets in the area to help recruit them to the platelet plug. Thromboxane stimulates aggregation of those newly activated platelets at the site of injury. Once the platelets are recruited, small amounts of fibrinogen is going to bind to GP2B3A on the activated platelets. As platelets are continued to be recruited and fibrinogen continues to bind, a dense plug is eventually formed. Once the platelet plug is established, secondary hemostasis can begin. This process results in a robust blood clot that is more resistant than the initial platelet plug. We divide this process into extrinsic, intrinsic, and common pathways. Key components here include the platelets and endothelial cells, coagulation factors, fibrinogen, and calcium. Ultimately, the goal of secondary hemostasis is to convert fibrinogen in the platelet plug into fibrin. Fibrin is better able to resist wear and tear and stop the bleeding. The main converter between fibrinogen and fibrin is thrombin. In order to activate thrombin, we need activation factors 10 and 5. Keep an eye out for these factors while we go through each pathway. We will start with the extrinsic pathway, since it is the pathway that initiates the generation of thrombin. The extrinsic pathway is mediated by factors 7, 9, and 10, tissue factor, which is factor 3, and calcium. After a vessel injury, tissue factor on the endothelium is exposed to blood circulation. Tissue factor activates factor 7 and binds to it, forming a complex along with calcium. We call this complex the extrinsic tenase complex. The extrinsic tenase complex is able to activate factors 10 and 9. Factor 9 we will meet again later, as it helps form the intrinsic tenase complex in the next pathway, while factor 10 will also have a larger role later on, but for now it is going to activate a small amount of factor 5. Activated factor 10 and factor 5 combine with calcium to form the prothrombinase complex. This complex is able to activate a small amount of thrombin to help initiate clotting. So ultimately, the extrinsic pathway produces factor 10, which starts an initial clotting process by activating factor 5, forming a complex, and then activating thrombin. It also produces factor 9, which will help amplify thrombin generation in the intrinsic pathway. The intrinsic pathway increases the thrombin generation capacity of the blood clot. As mentioned earlier, thrombin is necessary for fibrin formation to make the clot more robust. The intrinsic pathway is mediated by factor 2, also known as thrombin, factors 8, 9, 11, and 12, calcium, and some contact factors like high molecular weight kininogen, prekallikrein, and collagen. The intrinsic pathway begins with the contact factors, which are usually found on the endothelium, and they activate factor 12. Factor 12 then activates factor 11, which activates factor 9. The small amount of thrombin produced by the extrinsic pathway then activates factor 8. Active factor 9 and factor 8 form a complex with calcium on the surface of an activated platelet. We call this the intrinsic kinase complex. This complex can activate factor 10, which will join the common pathway next. Ultimately, the intrinsic pathway produces intrinsic kinase complex, which activates more factor 10. The intrinsic kinase complex contains calcium, factor 8, and factor 9. In order to produce factor 8, we needed the small amount of thrombin produced by the extrinsic pathway. The factor 9 can either come from the extrinsic pathway after being activated by extrinsic kinase complex, or it can come from the intrinsic pathway cascade involving factors 12 and 11. From here, the factor 10 produced by both pathways will have a key role in thrombin production in the common pathway. As more thrombin is produced, it creates a positive feedback loop and amplifies its own production, rapidly forming a blood clot. The common pathway is mediated by intrinsic kinase complex, prothrombinase complex, factors 10, 5, and 13, thrombin, and fibrin. The thrombin produced by the extrinsic pathway, or activated factor 10 from either pathway, can activate a small amount of factor 5. That activated factor 5 combines with the activated factor 10 from either pathway to form the prothrombinase complex. We saw this when we discussed the extrinsic pathway previously. From there, prothrombinase activates more thrombin. In turn, the activated thrombin activates more factor 5, thus making more prothrombinase. Thrombin can also activate factor 13, which we will come back to in a second. Thrombin acts on the fibrinogen in the platelet plug to convert it into fibrin. From there, factor 13 stimulates cross-linking of the fibrin to make it insoluble, forming a waterproof barrier. Now that the clot has formed, the platelets contract, which reduces the size of the aggregate and restores a relatively normal blood flow. So the common pathway converted fibrinogen in the platelet plug into fibrin. This makes it more robust so it can resist external forces. After the platelets contract, blood flow can occur, but it still may be restricted or turbulent. Therefore, the body begins fibrinolysis in order to restore blood flow completely. Fibrinolysis is the process of dissolving a blood clot after it forms. It is actually initiated at the time of vessel injury, but it is inhibited by thrombin until the blood clot has formed. Fibrinolysis is mediated by tissue plasminogen activator, plasminogen and plasmin, and contact factors. Plasminogen initially localizes to the sites of fibrin deposition. Here, tissue plasminogen activator, released by the damaged endothelial cells after the initial injury, will convert plasminogen into plasmin. The plasmin stays attached to the fibrin of the initial blood clot. Plasmin degrades that fibrin and releases products called fibrin degradation products. These products inhibit further coagulation in several ways. They can coat activated platelets to inhibit their aggregation, they can inhibit thrombin directly, and they can inhibit polymerization or the cross-linking process of fibrin. So through fibrinolysis, the fibrin within the clot is broken down in order to remodel and reshape that clot. During this process, fibrin degradation products are released, which provide negative feedback on coagulation and prevent further clotting. They can do this by neutralizing activated platelets, inhibiting fibrin polymerization, or inhibiting thrombin. Now you might be wondering, why isn't blood clotting all the time? How do we prevent clotting during homeostasis? The answer is anticoagulation factors. The main factor preventing coagulation is an intact endothelium. Having an intact vessel lining prevents exposure to tissue factor and von Willebrand factor. Endothelial cells also released prostacyclin, nitric oxide, and adenosine diphosphatase, which inhibit platelet activation. Other anticoagulation factors on the endothelium include thrombomodulin, heparin-like molecules, and tissue factor pathway inhibitor. Thrombomodulin is an anticoagulant compound that converts thrombin into a different form that is no longer able to activate coagulation factors. Instead, it now activates protein C. Protein C is able to inhibit factors 5 and 8, thus preventing coagulation. Heparin-like molecules on the endothelium bind to and activate antithrombin 3 in the bloodstream. Antithrombin 3 directly inhibits thrombin, as well as factors 9 through 12, preventing coagulation. Finally, tissue factor pathway inhibitor binds to and inhibits the extrinsic kinase complex, preventing completion of the extrinsic pathway. Now that we have an understanding of how coagulation works, we can apply this knowledge to coagulation disorders. Thrombocytopenia refers to low blood platelets. This affects coagulation significantly, as without adequate platelets available, no initial platelet plug can form. There are several potential causes of thrombocytopenia. Decreased production of platelets in the bone marrow can occur due to radiation injury, cytotoxic drugs, or infectious diseases. Increased destruction of platelets in the bloodstream can occur in immune-mediated or infectious disease. Finally, diffuse endothelial damage, or the syndrome disseminated intravascular coagulation, can cause increased use of platelets, resulting in a reduced number of platelets available for clotting. Thrombocytopathies are conditions where the platelets are unable to adhere or aggregate at sites of injury. Without these processes, no platelet plug is able to form. These conditions can be congenital or acquired, and we will discuss a few of them now. Von Willebrand disease is a condition resulting in the destruction of von Willebrand factor by autoantibodies. This prevents activation of the extrinsic pathway, as there is no von Willebrand factor binding to platelets. This condition has been reported in dogs. Bernard-Soulier syndrome results in a deficiency of GP1B, which prevents platelets from binding to von Willebrand factor. This condition is primarily described in humans. Storage pool disease prevents the release of granules from the platelets, preventing them from activating and recruiting other platelets. This condition has been described in Cocker Spaniels. Shediac-Higashi syndrome causes defective storage of ADP within the platelet granules. Without ADP, the granules are unable to activate other platelets to recruit them to the platelet plug. This condition has been described in mink, cattle, cats, and whales. Nonsteroidal anti-inflammatory drug administration is a potential acquired cause of coagulopathy. These drugs reduce the production of thromboxane, which is important for platelet aggregation at the site of the platelet plug. Finally, Glanzmann's thrombasthenia results in defective GP2B and GP3A, which is responsible for fibrinogen binding to the platelet plug. This condition has been described in Great Pyrenees and horses. Coagulation factor deficiencies can also occur, where one or multiple coagulation factors are unable to participate in the coagulation cascade. These conditions can also be congenital or acquired. Hemophilia A is a congenital disease causing deficiency of factor 8, which is part of intrinsic kinase complex. Similarly, hemophilia B causes deficiency of factor 9, which is the other component of intrinsic kinase. Vitamin K is a cofactor for the coagulation factors 2, 7, 9, and 10. Therefore, vitamin K deficiency disrupts all three pathways of coagulation by preventing formation of intrinsic kinase complex, extrinsic kinase complex, and prothrombinase. A somewhat similar condition, called gamma-glutamyl carboxylase binding disorder, is a condition that prevents vitamin K from binding to coagulation factors. This condition has been described in Devon Rex cats. Most coagulation factors are produced in the liver. Therefore, liver failure can result in decreased coagulation factor production, resulting in coagulopathy. Disseminated intravascular coagulation can also result in depleted coagulation factors, as this condition results in widespread blood clotting that rapidly uses up the available coagulation factors. Finally, hypercoagulability can also occur. There are numerous potential causes of too much blood clotting. Causes can include inflammation, enhanced platelet activity in disorders like diabetes, neoplasia, or uremia, increased clotting factor activation in DIC or neoplasia, antithrombin 3 deficiency from DIC or liver disease, metabolic abnormalities, and genetic mutations. Now, I have mentioned DIC a couple of times, and I mentioned it as both a cause of hemorrhage and a cause of coagulation, which seems a bit contradictory. This is an interesting condition causing excessive activation of hemostasis, initially causing excessive blood clotting. This blood clotting is initially kept in check by the anticoagulant factors like antithrombin 3. However, once those factors are used up, unchecked thrombosis can occur throughout the body. This rapidly uses up the available coagulation factors. Once those coagulation factors deplete, the body is now unable to form clots, resulting in a widespread hemorrhage. This particular condition can be triggered by several different diseases, including infectious disease, neoplasia, inflammatory diseases, causes of intravascular hemolysis, and some toxins. To finish up, I wanted to give you guys some helpful ways to remember the important factors in each clotting pathway. For the extrinsic pathway, we primarily want to think about tissue factor, otherwise known as factor 3, and factor 7, as these are what's going to form the extrinsic kinase complex. Extrinsic kinase complex is then going to go and activate factor 10. You can remember this by thinking that 3 plus 7 equals 10. For the intrinsic pathway, it involves factors 8 through 12. You can count 8, 9, 10 in order, as factors 8 and 9 are going to form the intrinsic kinase complex, which will then activate factor 10. Finally, the common pathway produces prothrombinase from factors 5 and 10, which activates thrombin, also known as factor 2. So you can think of 10 divided by 5 is equal to 2. I hope you find these mnemonics a little bit helpful. Thank you for watching PathoLogic, and we will see you in the next one.